Good afternoon. I'm Joy Dobson. I'm an anesthesiologist who's in the Lean Leader certification training. And you see our standard work combination sheet up on the screen for our report out with a tack time or cycle time of 20 minutes. And this is our team, and I have to say they were everything Marlene and I could hope for. We were a rocking team, and we really made a lot of changes this week. Our RPIW was tasked with reducing the lead time for a patient visit to the Surgical Assessment Center, and we wanted to cut that in half by improving the quality of the visit. The purpose of that visit by the patient is to prepare them for their surgery. The basic process is that a few days or a few weeks before the actual surgery date, the patient arrives at the Regina Center crossing and registers for the visit. They are then seen by a nurse and a lab tech, and also usually by 1 or 2 doctors, anesthesia and internal medicine specialists. And after ensuring the patient is medically and psychologically prepared for their surgery, the patient leaves the clinic and is ready to show up for their surgical procedure at any one of the Regina Qu'Appelle Health Region surgical facilities.
Good afternoon. I'm Marlene Smedu, Vice President of Quality and Transformation, and I was the sub-team lead for RPIW number 21. So as with every RPIW, we created our baseline measures for the key targets that we wanted to look at and to make improvements on related to our overall goal of reducing the lead time for patients coming into the pre-admission clinic. I want to draw your attention to a couple of them particularly. They actually are ones that we believe need to be audited. But one was the number of examination rooms that we were using at the pre-admission clinic, which in and of itself sounds pretty innocuous. But we ended up realizing that several of them were not actually used all of the time for examination. They became waiting rooms for patients. And so that the more space we had, the more the people were able to function with having them as waiting rooms rather than actually being used as examination rooms. And of course, our second major target was that reduction in lead time. The staff at the pre-admission clinic has done a lot of amazing work. People are coming to the patient. The patient isn't traveling all over, but there are still lots of waits, and those were things we wanted to reduce. The current state map shows basically what was on the project form that Joy just went through, but there were a number of waits both within the visit and before and after the visit of the various practitioners, and we mapped those on our current state map. We also did on the bottom, the little yellow sticky notes, we looked at what each of the providers, so the nurse, the anesthesiologist, and the internal medicine specialist were doing, and found out that they were all doing histories, they were all doing physical examinations, they were all doing other kinds of assessments, and that was where we thought we could get some value added for the patient by reducing duplication. The future state map is much more straightforward, and one of my favorite things is on there, which is self-rooming. We're not there yet, and it probably isn't a big issue at this clinic because it's the nurse now who goes out to get the patient and begins the conversation. But the idea that they would walk in, go into the room, have everybody come to them in a very concise and integrated fashion, and then leave in a timely fashion. We did our calculation of tack time, and the good thing about the clinic is that they are actually meeting their capacity needs at this time. The bad thing is that there is still lots of wait for each individual patient, and we anticipate with increasing surgical volumes that we actually may need more capacity. So it's really important for us to know a patient needs to leave the clinic every 30 minutes, and we need to make sure we've got everybody lined up so that that happens. So we came up with sort of actually 5 big groupings of Kaizens. We wanted to make sure we avoided duplication, eliminate interruptions. That was the first area. You're going to hear about that. We didn't want patients left alone. Once they were in contact with the team, they should be with somebody all of the time. We wanted to reduce duplication, so not answering the same question 10 times. And the fourth one was our safety defects, which was we chose specifically hand washing. Our 5th Kaizen was 5S, which you'll hear about.
Good afternoon. I'm Lori Carlson, the Executive Director of Mental Health and Addiction Services and a participant in this RPIW. I'm going to start by telling you a little bit about the pre-assessment clinic. There are, for staffing, there are 9 nurses, 6 doctors, 1 anesthesiologist, and the other 5 are internists, and there's 1 lab technician. In terms of volume, they see about 6,200 patients per year, and they're open about 261 days per year. What this means is that they see 30 patients per day. 15 of these patients see the anesthesiologist, 20 of these patients see the internist, and all patients see the nurse and the lab tech. As mentioned before, this clinic was meeting its demand, but the patient waits were long and the workflow for providers was chaotic. If you look at the picture of room occupancy here, this is a picture of room utilization for one day. The gold is the amount of time that the rooms are actually empty. The white is a patient waiting alone in a room. So when you see those two areas added up, there's a lot of waste in terms of exam room time. The one process that we looked at was the lab tech process. She has a very standardized and predictable process. It was already patient-friendly, but she did have to travel across and into another hallway to get to her work area in red there. So she has to do data entry and then come back and perform her procedures on patients. We decided to do a trial by moving her lab area actually into the first exam room. Our idea was that as patients came by with their nurse, they could stop in the lab room first and then go into the patient exam room. On the trial, we decided that this wasn't a good trial because it actually increased patient movement. The next trial we did was to have the lab tech still located in exam room 1, but have her travel to the patient rooms. With this as the process, she has much far less way to travel, and the wait time between patients is less. Thank you.
Good afternoon. My name is Sandra Khadijah, and I'm one of the registered nurses at the pre-admission clinic. One problem that we identified was that patients had way too many interruptions, as you can see from the video. Doctors coming in before the nurse was finished her work, and vice versa. We identified what part of the assessment the doctors needed most to do their work, and had the nurse complete that portion first. Then we developed an and-on system, signaling system, which would let the doctor know when the nurse and the patient were ready for them. This also alerted the remainder staff in the building as to who was in the room, who was out of the room, as the signals indicate. Whiteboards on the outside of the exam rooms were often disorganized and unclear, indicating the name of the patient, what tests were being done, which doctor was to be there, and also the nurse's name. By simply labeling the boards, information is now complete, consistent, and concise.
My name is Dr. Dan Ene. I'm a specialist in internal medicine at the General Hospital and participated in RPIW number 21. I'm going to report the things which are going to be of interest to the doctors who work in the center. We identified right from the beginning that the idea that the doctor traveled a lot of feet to go from seeing the patient and going back to dictate. And we thought by doing the spaghetti diagram as well as the patient transit time that we could make some good changes there. Pre-Kaizen. Post-Kaizen, we found that after transferring the patient's room, the dictation room to one of the patient area, the doctor could finish his work in time, and on exiting from the room, he had direct view of the place he was to go to next. So he was able to proceed between patients within 30 seconds. One other advantage we put to use was having the nurse stay with the doctor in the room at the same time. Among other benefits, there were no contradictions in instructions given to patients, and there were no delays as well. We were able to design, from the time the patient spent in the clinic, a average wait time of about 20 minutes. With this, scheduling was made much, much better and less chaotic. If you look at 2012, it was quite chaotic. And knowing that you could put through 20 patients very easily per day at 20 minutes a time, we could now schedule the doctors better in the clinic with less interruption for doctors and for patients. We were also able to design 2 forms. One was a patient checklist of symptoms, which the patient could fill out, or the nurse will fill out, which allowed the doctor to come to a conclusion whether the patient was safe for surgery or not, or to make modifications necessary for the surgery. We're also able to have a standard list agreed by the anesthetists and the physicians together of medications to stop or modify pre-op. Thank you.
Good afternoon. My name is Marlene Robertson, and I'm a registered nurse and a participant in this RPIW. One of the objectives was to reduce duplication of information during the pre-admission visit. So we have produced standard work for unit secretary for chart order to help accomplish that. The chart will have all the documents and forms the doctor requires on the left side, and the remaining forms will stay on the right side. And here is the pre and post Kaizen info regarding a pre-admission visit. There's also a standard work form created for the nurses. The nurses will complete the information the doctor needs first and follow the same process order. This process allows the nurse to remain with the patient, so the doctor should be able to find what he or she needs without searching through the whole chart, and the nurse being present can inform the doctor about any issues the patient may have when they come in to do the warm handover. They can share information and also hear instructions given. The patient feels we're all on the same page, and there's less chance of error and confusion. And the doctor and nurse won't need to search out each other and relay information. Time will be saved for everyone, especially the patient, and hopefully avoid this.
Hello, my name is Arlene Stuber. I'm one of the RNs at the pre-admission clinic and also a participant in the RPIW 21. A safety defect was identified, which was inconsistent hand hygiene by providers, both nurses and doctors. So hand hygiene training was provided. Providers were certified to train other providers, and I'm one of those. It involved isogel use, hand washing training, and isogel pumps were placed in the entrance of each exam room. As well, signs were also placed on each exam room door to remind everyone to wash their hands when entering the room and prior to interacting with the patient. Also, patients are encouraged to remind their provider to practice safe hand washing or hygiene practices. Thank you.
Hi, I'm Glenda Little. I am the Director of Certification and Training with the Kaizen Promotion Office and a participant on this RPIW. This is our present load chart. What it illustrates is the time providers spend on their main work activities by color, including setup time before and time between patients. What pre-Kaizen shows is that there was duplicate work between providers and the work was done sequentially. It also shows that nurses were not meeting the 30-minute tack time, verifying that more than one nurse is required per physician. What post-Kaizen shows, as you can see, the nurse's time has decreased by 15 minutes by transferring some of the setup and paperwork to the unit clerk. The work of the nurse with the lab tech and physicians has also been grouped by having the nurse in the room with these providers. This has resulted in increased quality and safety for our patients by eliminating duplication, rework, and any confusion with orders. Now to our mini 5S. We 5S'd a cupboard in the clinical educator's office. So our pre-Kaizen photo, it looks pretty darn good. But it had old information and there wasn't a system where things go, as well as there was unused file holders and over 25 unused binders hiding in the back. And patient information was just stacked in the bottom shelf. So our pre-5S score was 1.5 out of 5. So for post-Kaizen, we have everything in alphabetical order. Everything's in its place, and there's a place for everything. And the unused file holder now holds all that patient information. So our post-Kaizen score is now 2.3 out of 5. Thank you.
Good afternoon. I'm Cindy Duma, a patient participant for RPIW number 21. I was privileged to be invited to take part in my second RPIW. I never dreamed that words like Kaizen, Kanban, Andon, idea sheets, time ob sheets, spaghetti diagrams would be part of my vocabulary, and let's not forget standard work. This week, once again, has been challenging, exhausting at times, but always fun and rewarding. It really gives a patient a new perspective on how our health care is delivered. It's much more complex than most of us realize, and once again, I have a new appreciation of the work involved to ensure best patient experience. I found that while these intense weeks are structured the same, my experience from the first RPIW to the second one was very different. Our team was working in an entirely different area this time, delivering a different type of patient care, so of course, there were new and different challenges and new solutions. Both RPIWs showed great improvements as the week progressed, with one constant being that the members of our healthcare teams discovered how much their work in the process affects one another. All entities in the process were asked for input, leading to better understanding and cohesiveness. I was able to follow a patient through their journey one day during trials post-Kaizen, from the time they entered the clinic until the end of the visit with the nurse, lab, and specialist. This patient left the clinic well-informed and ready to go for surgery and expressed a great experience in PAC. I'm confident that the improvements implemented at the pre-admission clinic this week will continue and improve even more as the staff there is dedicated to ensuring this will happen. It's been gratifying to be part of this team, to be welcomed as a valued member, and to be heard. Thank you.
Marlene Smedu again. I'm going to talk about the newspaper. The process owners are going to be very happy to know that we have actually closed off all of the 42 items on part 1 of the newspaper, and we're just going to show you a little bit of part 2 of the newspaper. These were the items we were working on in the last day or so, and they can kind of be grouped. The one you already heard Arlene talk about, we've just really nicely started the hand washing campaign. Both Arlene and June are already certified trainers. There will be others soon. That will carry on in the next month. We're suggesting more work be done on some of the evidence-based best practices, specifically around patients with sleep apnea and the kind of checklist that can be used, and that we are hoping the physicians can provide that leadership. The biggest issue is the scheduling and the waterfall scheduling. These schedules are made, everybody's schedule, including the patients, are made well in advance, so we couldn't make all of those changes this week. What we were able to try this week showed great promise, and we know that that scheduling is on the agenda for the process owners, so we look forward to them being able to move on that.
So, Joy Dobson again. We've got 2 minutes, and I think we're going to meet our TAC time. At the end of our 5 days, we were able to achieve gains in most of our target measures. We did free up 2 exam rooms, which was about 300 feet, and we were able to redeploy those to make the work easier and better for patients and for staff. We expect to see a further reduction in that as we continue the improvements. As Marlene has said, much of the work was actually contingent on us being able to schedule the patients and especially the physicians differently. But despite those delays, we were able to reduce the lead time for a patient visit there by 49%. And you've heard how that was done by reducing the waits, both alone in the room or waiting for a doctor. And we also were able to improve the quality of that time that the patient spent with doctors and nurses together in the room. So we made it easier for the staff and the doctors to do the job right. And we know that we'll continue to see further improvements as we implement that new schedule. So we did lots of things, but mostly we made it better for our patients by making what seemed to be some pretty simple changes. We created standard work for all team members. I can't believe the amount of standard work we did, but we sure had a lot of hard lessons while we did it. Mostly that batching causes chaotic flow, that you need to communicate the change ahead of time to prepare people, and that making defects visible is a good thing because then you know what you have to work on fixing. We've got lots of people to thank, but most importantly Cindy, who volunteered to keep us on track every time we tried to get off. and the patients at the clinic who saw more chaos this week than anyone anticipated. But we had a great team that responded very well to all the stress. And so the good news is that now we get to celebrate those improvements